Okay, guys, I'm going to just keep on rolling. I'm Ryan Erdley, primary care sports medicine, and Neil asked me to do a talk on ultrasound guided injections. When we talked about what we would talk about, we decided to focus on knee and shoulder stuff, and with the purpose that for people that are trying to get into ultrasound and incorporate into their practice, kind of show ideas and things that you can readily start to do, and to be honest, they're not that difficult. So that was the kind of goal for today. So I won't be going into nerve blocks. I won't be going into some of the intratendinous hip injections, but that's kind of the focus for today. This is me. I work out of a clinic here in Toronto. No conflicts. So first off, why do ultrasound guided injections? The main thing is kind of accuracy in patient care. I'm sure a lot of you have read the studies on it. It just tends to be more accurate. There's been studies that have looked at the cadavers and looking at AC joint injections, about 90% accurate compared to the palpation-based approaches. Same thing with shoulder glenohumeral joint injections. So if you're trying to improve your accuracy and thus improve your outcomes and your patient care, I think there's a really good argument for it to be made. Now, there's always the issue with time in a busy clinic, whether or not it's reasonable. 30, 40 patients a day, sometimes you can't all the time, but if we're talking strictly about patient care and accuracy, I think there's a great argument for it to be made. Now, with ultrasound, it was one of these things that was really cost prohibitive for a lot of clinics, especially if you weren't working in a hospital setting. You didn't have funding. These big, large machines, they're 20 to 100K for some of these things, right? So average clinic to buy them is not reasonable. If you have funding, you can secure it. Yeah, maybe. But with most things with technology, that has changed. A lot of the handheld probes now that we have, they're not bad. Is the accuracy and the echogenicity in the picture you can generate as good as some of these guys? No. But for the purposes of some of the stuff we're talking about today, it's usually adequate. So the Clarius and the Butterfly IQ, the sports fellows, they use the Butterfly IQ. The technology is in the transducer, and it's either crystal technology or slightly different with the chip technology. It plugs into the phone, very portable. You can carry it around. You can do guided injections with them. And in terms of cost, you're looking at less than 5K. Then there's a monthly subscription cost, though. That's how they get you. It's like $100, $150, whatever it is. But if you're looking to incorporate it into your clinic and you don't want to get the upfront costs, because they are expensive, these larger machines, this is a great way to start to incorporate some of it into your practice. So just a few terms before we get started. In-plane versus out-of-plane. It's important just because of how you view the injection and how you see the needle. So an in-plane approach, the needle is in line with the transducer. So you're going to see it as you inject through the tissue, and you'll see the needle all the way through, as long as you're keeping the transducer perpendicular to the needle. Now, in an out-of-plane approach, conversely, the needle is crossing the transducer perpendicularly right across. And as a result of that, you will only see the needle when it's directly over top of the transducer. So it looks like just a small dot or a pinprick. So you won't see the whole needle as you're doing it. Why would you do that? Well, some of the joints, especially some of the smaller joints or some of the areas, it's actually easier and better to do it as an out-of-plane injection. And there's an example of that today, so you'll see that as well. So let's just kind of get right into it. So in terms of the knee, there's a couple ones that people can start to look at as an ultrasound guided procedure that you might be able to do fairly regularly, and that's if somebody has a large knee effusion, they're coming into your office. I frequently get, I had a referral the other day for somebody who the family doctor had tried to aspirate, couldn't get much out, maybe got 2 cc's, and you're looking at it and it's a huge effusion, it's clear. So sometimes incorporating the ultrasound into it is a great way to do that, and not only to make sure that you're getting the fluid, but also make it less painful for the patient actually, because sometimes if you're prodding around adjusting the needle, it's not too fun for them. So what you're looking for, just to review the anatomy, it's the suprapatellar bursa. So it comes up just superior to the patella. and it's communicating intra-articularly with the joint, so readily something you can see. And so this person comes in with a big effusion, and if you're looking at fluid on an ultrasound, it's hypoechoic, so it's very, very dark. And if it's a fluid-filled sac or area, like in, wrong way, fluid-filled sac or area, you should be able to compress it. Technical difficulties. So here, all that's happening is I'm actually just pushing down with the probe, and you can see the fluid start to go away. So you know it's fluid-filled sac. Why that's also important is sometimes people come in with large hematomas. They got a large hematoma direct below to the quad or something like that. They're 2 weeks post, and then sometimes that hematoma or collection has really coagulated. And you look at it, and it's not all black like this. There's little stuff all coming through it, and then you go to compress, and some of it doesn't compress down. Those are areas you will not be able to aspirate very readily, and it'll make it very difficult. So that's a quick way you can really easily test, just as a tip, that if it's a fluid collection, you think you can aspirate pretty easily. So this is an example of that. So this person, knee arthritis, flare, effusion. So this is a suprapatellar approach, as you can see. The approach is going to be an in-plane injection, in this case an aspiration, and then you can see down at the bottom here there's some cortisone, there's some freezing. So what I like to do in this case, patient is lying on their back, the towel or some kind of, in this case there's towel wrapped with some paper towel underneath, 30 degrees of flexion, it just makes it a little easier to get that bursa. And then one of the problems is the fluid sometimes is more lateral than you think, or more medial than you think. It's not right on top. And just because of where they are, and then the fluid falls on the sides. So oftentimes you'll have to adjust your probe, and depending on where the fluid collection is, that's the great part with the ultrasound, you can identify that. Now this patient already had some freezing, they've been cleaned, they had freezing. I give them a little bit just of like one or 2 cc's of 1% xylocaine. And then I use an 18 gauge needle. So it's an 18 gauge needle going in. It just makes your job easier. If you got a 22 gauge and it's some degree of debris in there, sometimes it get clogged. It makes it a lot easier for you if you do it with an 18 gauge, I find. So 18 gauges going in. And then you'll see the needle, it's an in-plane injection. So you'll see the needle pop into the screen there. And then you'll literally feel a poke as it pops into the bursa. And then you can just aspirate with the other side. Now this, I'm fumbling with the probe because I'm trying to take pictures with the probe at the same time. So sometimes it makes it a little awkward. Usually it's not that difficult. But so again, I'll just try to play it again for you. This is proving more difficult. Sorry for this back and forth.
This is fantastic to be able to see both.
Yeah, I tried to, because it's tough when you just see the needle go in, but you don't really see where, how they're doing it. And then aspirating just with the same hand just to draw the fluid back out. So suprapatellar aspirations, great, easy thing you can do in clinic. These small probes, you can easily do it. And then in this case, I'm giving them some cortisone with it as well after the aspiration. So I just leave the needle in, change the syringe, add the cortisone in, push it in, and it's easy. Patients love it.
Ronnie, can I say one thing?
Yeah.
Okay?
Absolutely. Go ahead.
Appreciate it. I was looking at learners in here. I don't know if you do this as well, but if you want to get all the fluid out, which may not be necessary, but
Yeah.
I'll even express that fluid.
Yeah.
So that suprapatellar space, so you can use your probe hand and just sort of, it's almost like a milking maneuver. And
Yeah.
you get, that
Yeah. Absolutely. And that's a great point because, again, sometimes it collects on one side. So if you use your other hand, you can kind of push it. Because you look at it, it's like, oh, it looks like there's some in there. Why is it not coming out? And usually it's off to the other side. But that's a great tip. Baker cyst, you'll get these all the time. People come in, stiffness, pain. They want their Baker cyst gone. They come back. Part of it is educational, obviously, letting them know that, these are going to recur. But sometimes they're quite large. They're really discomforting for people. And if you aspirate them and if you give them some cortisone, they can stay away for a while. They will come back. This is in the setting of somebody with knee arthritis. Now, I put this one in because you will see these in the office, and you can readily do them. A true Baker cyst comes between the two muscle groups, the semimembranosus and the medial head of the gastroc, so it'll come in that area. But the thing you got to be aware of if you are going to do these is this little pulsating thing underneath the needle there. So you don't want to hit that. As long as you don't, great. Okay, but it's really easy to do. Doing these, especially if they're under ultrasound guidance, they can be quite restrictive and painful, and patients can barely flex their knee, and you can give them a good amount of relief for some period of time. So this is something that, again, you can't do in office. If they're small, I would not recommend them. I'd wait till they're really quite large and patients are really struggling despite conservative measures. But that's one you can easily do as well. Shoulder subacromial injections. These are something we were doing landmark-based forever, and we do them all the time, ultrasound guided now. Different indications: impingement pain, bursitis, partial rotator cuff tears, may have full thickness rotator cuff tears, aspirating a fluid collection. When you're doing it ultrasound guided, your position is really important. When the patient's arm is just at the side there, you can see the humeral head here, and this is the supraspinatus tendon. And then there's the acromion here, this bone here. But what you want to access is kind of in this area. And when their hand's down at their side, it's a little difficult. So you have them internally rotate their hand. We call it the CRAS, or the modified CRAS position. And that just brings that tendon, that little asterisk point out from underneath the acromion, and it makes it easier for you to access the space. So the position is important. Whenever you're doing an ultrasound-guided injection or procedure, make sure you're comfortable. Positioning, your setup, everything's got to be good, and it just makes your life a lot easier, especially when you have to troubleshoot an injection, because that will happen. And making sure you have the right setup just ensures you have better success. So this girl, she had a big bursitis. I'll explain as we go here, but this is just a subacromial cortisone injection. There's a little freezing and some cortisone. And her hand's internally rotated to bring that out of that space. Now, I was fumbling with the probe to try to get the video, and it didn't work. But she was kind enough to let me inject her other shoulder. But I didn't inject anything. She's a very nice lady. But I didn't inject anything. You'll see here, but just to show you. So you'll see this needle pop in. So you're seeing the arrow doesn't come up. So you'll see this needle pop into view at the top of the screen, and then it just enters that black space. That's where you want to do the injection. That's that subacromial area you want to be in. Now, I just want to play this again because this is something you'll see often when you're doing injections, especially when you're doing an in-plane injection. So it looks like my needle's like right where it should be, but if you look at the top of the left screen, you see this movement of tissue, but you can't see a needle. And then all of a sudden the needle just pops in view. It was already in. It's just the transducer wasn't directly over top of the needle. So sometimes when you're seeing the movement, or you're in the skin, but you're not seeing the needle, don't advance. Wait until you kind of move your probe back and forth till you have the needle in plane, and then you can see it. That's why it pops into view like that. And then you're doing that injection. Now, I didn't actually inject here, unfortunately, because I'd already done it on the other side. But that's where you would be putting the fluid if you're doing a subacromial injection, cortisone, freezing, or whatever you're doing. But again, something you can readily do in clinic. Let me see here.
And with the workshop this afternoon, you're going to be able to practice essentially that needle identification, both in short axis and long axis, with the varying ultrasound units on the ballistic bell models.
The other one from a shoulder perspective is shoulder joint injection, so the true glenohumeral joint. Traditionally, the teaching is posterior. I actually like anterior directed approaches. I'll show you both. Anterior I find is just simpler. So when you're doing an anterior glenohumeral joint injection, your main landmarks are going to be your coracoid and then the head of the humerus, and then you'll see the anterior capsule at the front. So on the screen here, this is the coracoid, and then this is the humerus. So it's actually mimicking the picture. So it's the same kind of setup. Left is left, right is right. And then in this case, this is a patient who had a large effusion. They had bad glenohumeral joint OA. And all this black stuff, that's all fluid. It's that speckled kind of appearance. That's all effusion inside their shoulder joint itself. I didn't do anything here, but that's something you normally won't see in a patient, but just to show you that space communicates up and readily accessible. So when I'm doing an anterior glenohumeral joint injection, the setup, this is where you're entering that out of plane approach. So you'll see a couple things, just troubleshooting. Probe, and then the probes usually have like a center line or mark, and that center line or mark will usually match up with something on your ultrasound machine. So you see the yellow arrow there at the top? That's how you know you're in the same area. So when you're doing an out of plane injection, your needle will advance, but you will not see it advance until you cross the plane. And then you'll see a small needle point come through, or you'll see the injecting material go through, depending on what level you're at. But so when you're doing an out of plane injection, making sure you're right where that needle is, that marker, that will ensure you're in the right area. So I'll play the first, just the middle video here. And what I want you to pay attention to is there's no injection, but I want you to pay attention to the top subcutaneous area there, because you'll see the marker in the skin. So initially, there's this little kind of like, trying to see this little, the white line at the top kind of gets an indentation. And that's, I'm pushing down to know that I'm in the right area. I know that I'm going to be advancing into the right direction. So that's just a quick, I'll play that one more time. It's a little tough to see in here. But, so you'll see this little, just kind of poke at the top. And initially it's too far left of the yellow line, and it would hit actually the coracoid. It would hit that bone. So you want to come over a little bit more, then you know you're going to go into the capsule. Then I'll show the injection itself. So at the bottom of the screen, what you're going to see is this injectate stuff, this white stuff at the bottom here. And that's the injection. That's all you're seeing. So you don't actually see the needle coming in this plane. You can see it at the very bottom. Again, I'll just play it again. I know it's a little tough to see, and I'll just go on the other side. But it's this white stuff down here. And you're in the capsule itself as you're doing the injection. So big tip here, whenever you're doing an injection, making sure you're right where you need to be. Just lightly pressing on the skin as you do your needle mark. But obviously before you clean, you know you're going to be in the right spot. Another one, so you can do them posterior directed as well. This is a traditional teaching, landmark-based approach going towards the coracoid. With this one, the patient positioning is usually so they're kind of on their side, or you could do it with them sitting, arms kind of across their chest. And what you want to do is you're aiming for the capsule itself. So here's the socket, the glenoid, here's the humerus. This is the labrum, this white thing here, okay? You generally don't want to hit that. When you're doing the posterior glenohumeral joint injection, the blue is the marker. That's the capsule. So that's where you want to be. And as long as you're in that area, you're going to be intra-articular and be fine. So in this area, this is kind of where you want to be. I don't know if everybody over that side can see it too. So just show the needle advancing here. So you'll see the needle coming from the left-hand side of the screen, advancing down, and then entering the capsule. And then I had to take another video because they were moving a bit. And then you'll see the injection. And that's the fluid as the capsule itself is distending, but you're not actually hitting the labrum. Now with these ones, just as a tip, especially some of the ones with the larger body habitus, I use a spinal needle, the 3.5 inch, 22 gauge. Sometimes if you're using the 1.5 inch ones, you're not going to get there. Then you have to redraw. So I like using a spinal needle. You're not going all the way in for sure, but it just ensures that you don't have to re-poke them again. But the posterior ones, really easy to do. Sometimes you'll see labral cysts, you'll see joint fluid in there as well, and you can easily aspirate from that area of the joint. So I think those were kind of the main ones I wanted to talk about. But those are ones that you can easily do in clinic. Like you'll see them in your clinic as you get more familiar with ultrasound. They're ones that you just need to put your reps in. That's really all it is. And when they're big joints and not tendons, you have a little bit of leeway as long as you get into the joint itself. But yeah, that's it. Questions?
So that the posterior glenohumeral joint injection, you had the long axis and then the placement of the probe.
Oh, right.
Kind of at an angle.
Yeah, I didn't really. That's right. I didn't actually take a picture of it there.
You want to just, even with the.
Yeah. So your probes.
Do we have a? I remember no one's talking about stuff.
Yeah.
So probes just.
Can you use a spinal needle?
Thanks so much. 16 gauge.
Only the thickest.
So like, it depends. You can do two approaches for it. Like if you're doing a posterior gland rheumatoid, the one there, I was coming from this direction. It's just because how they work. Traditionally, you're gonna come this way. That's how most of the teaching is, and you're aiming towards the coracoid. That's your traditional landmark-based approach. But if you're doing it this way too, then what's going to happen is you're going to come from this direction, and you're going to be just trying to enter the labrum from this area here. So the needle's coming that way. I like doing it the other way sometimes because I find I don't have to get into this thin sliver. So I like it coming across. Now you do come through part of the muscle as well, but so you can do them either or. But the key is their arms kind of across this way. It opens the area, makes it a little easier for you to do it.
For the Baker cyst injections, are
Yeah.
you aspirating and then injecting cortisone right into it?
It depends what they want to do. Yeah, but yeah, oftentimes I'll tell them that there's a good chance this can recur quite quickly. So I'll try to get them to do the cortisone with it, and then yeah, needle is in, and after I've aspirated, keep the needle in, add the surgeon push.
And you find, like, are they particularly painful or not too bad?
They're simple. Patients love it, and then they're like, "Oh my goodness, you cured me! I'm amazing." So, but it's not a painful injection at all. Yeah, pretty satisfying for the patients and for you if you do them. Any other questions? No? Okay, great.